let me ask a question. One of the things that we talk about a lot in population management and across implementation of different disease states is the use of the guidelines. And so where are we with those, and how do you think they're reflecting practice? How do you think they'll be improved to improve practice? Dr. Desai.
Wow. Well, I think, it's always hard to know, where the guidelines are going to go. I think we've gotten some glimmers, at least from on the cardiovascular side with ACC and AHA and other, sort of professional societies, beginning to integrate this evidence and increasingly, I think, advocating for the SGLT2 inhibitors, particularly in terms of the patients with atherosclerotic cardiovascular disease and diabetes, right? That's where the first sort of 3 or 4 trials really came out. That's really where the SGLT2 inhibitors kind of first made their splash, to Dr. Nissen's point. I think in terms of the DAPA-HF data and how the professional societies will then integrate that and synthesize that into a guideline, I'm eagerly, awaiting kind of, what that document is going to look like. Because I do think that the clinical community would benefit from the professional societies coming forward and trying to make a statement about what they think best medical therapy is. And I think, we were talking about this before with Dr. Nissen as well, around, because you have such a broad number of therapies in the heart failure arena, how can one rationally use the therapies that are available? Because I think the last thing that our patients want to hear is, hey, Mr. Jones, hey, Mr. Smith, we have yet another pill to add on to the 240 pills, as in Steve's example, that they're already taking on a weekly basis. And so I think for us to be able to then, think about the patients first and really put them at the center of our thinking and have the guidelines really embody what clinical care should look like for them, I think would be very beneficial for the clinical community. And I think if one looks at the evidence on the heart failure side, and again, more will emerge, I think that an impartial sort of view of that would be the standard background therapy, beta blockers, RAS inhibitors, and MRAs, because the data is so compelling.
Let me just say that something a bit controversial here. We've all been kind of agreeing on everything, but as the evidence emerged around the cardiovascular benefits of some of the newer diabetes drugs, I was frustrated that the ADA was a little bit slow on the trigger. And there was a guideline, early on that basically said, give metformin and then kind of give whatever you want for the next step. And now they're gradually getting a bit better, but there was sort of a political correctness, not wanting to offend the makers of any of the drugs and not showing any preferences. And I get it. I understand that. None of us want to do that, but we have to go where the evidence is. And I find it very hard to advocate for certain classes. And I mentioned this before, I'm going to say it again. I find it hard to see patients get metformin and then get a DPP4 inhibitor, particularly people that are at high risk for heart failure, when we know that, in fact, at least one of the DPP4 inhibitors actually seem to increase the risk of heart failure. And so I think we've got to move a little faster on the diabetes side. And I would give the same criticism to the ACC/AHA guidelines. They've been historically inherently conservative, unwilling maybe to move as fast as the science moves. And it's an area of frustration that, even I, as a past president of the ACC, have been a little bit frustrated with my organization by not being a bit more proactive. And I think clinicians and academicians need to push these societies to get with the program and move a little bit faster on the guidelines.
Yeah, Neil, if I could just make one sort of comment, I think building on, which is incredibly well said, well taken, is literally today, across the country, there are going to be thousands and thousands and thousands of visits of patients that have diabetes and heart disease. And chances are that the numbers would suggest to you that they are much, much more likely to walk out of that office with a script for a sulfonylurea or a DPP-4 inhibitor than they are an SGLT2 inhibitor. I mean, that's just what the numbers would suggest. And I think that is a symptom of a diseased system. It's a system that is not delivering best quality, best value care to our patients. And I think everyone has a role to play in that. Professional societies, individuals, payers. I think, you know, patient advocacy groups, everyone has a role to play, because I think people deserve better. And I think what they deserve is that their providers are practicing evidence-based medicine, which I think there are too many instances where that's just not happening.
So let me
Neil,
ask questions to Dr. Morello, okay?
Thank you. I always get read your mind. No, I wanted to really reinforce a point which is critical for us in general, the payers, which is guidelines are very important to us when we design medical policies, because we base them on those guidelines. And if we don't have them, it really ties our hands in terms of how to move forward with it, and not for practitioners to say, well, that's because, you know, your company wants this. It really isn't about what our company wants. It really is about what the guidelines say. So it's extremely important that we have the ability to fall back into those guidelines in order to design a medical policy. The other point is they can, again, to stress the points that your panelists have made, we cannot wait 5 years to update guidelines. We're no longer in that space. We need to be more dynamic, and sometimes we have to be bolder in terms of moving forward and making sure that things are done on behalf of patients. No wait 5-10 years for that. And then to your point, Nihar, the last comment is extremely important, is we cannot also depend on the good doctors, and that only those who go to Dr. Nisa or Dr. Desai will benefit from the knowledge, or many others, but that everybody has access to the same care, at least close to it. And that's why I think having guidelines-based protocol designs, that minimizes that care, and that gives everybody the opportunity to benefit from what we believe, which is, yes, SGLT2 have a major place to play in this population, and everybody should have access to them.